Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today I am going to talk briefly on the topic metabolic alkalosis. Before we go to the topic, let us understand the meaning of certain of the terms used in acid-base disturbance. Acidosis. Acidosis is the situation wherein pH of the blood is less than 7.35. Alkalosis is the condition wherein pH of the arterial blood is more than 7.45. That means pH of the arterial blood ranges between 7.35 to 7.45. Okay. What is metabolic acidosis? When the serum bicarbonate level is less than 22 milliequivalents per liter, this is called metabolic acidosis. What is metabolic alkalosis? When the serum bicarbonate level is more than 26 milliequivalents per liter, it is metabolic alkalosis. What is respiratory acidosis? It is related to the PCO2. When the PCO2 is more than 40 mmHg, it is respiratory acidosis. What is respiratory alkalosis? And PCO2 is less than 22 mmHg. Okay. Respiratory acidosis and respiratory alkalosis is related to the level of PCO2, and that of metabolic alkalosis and metabolic acidosis are determined by the serum bicarbonate levels. Okay, so by and large, what are the determinants of acid-base disturbance? PCO2 and bicarbonate. Okay, then hydrogen ion concentration. Hydrogen ion concentration is inversely related to the pH of the blood. At a pH of 7.4, hydrogen ion concentration in the serum is around 40 nanomoles per liter. Okay? Hydrogen ion is regularly produced into the serum as a result of metabolic activity. What metabolic activity will release more hydrogen ions into the circulation? Protein metabolism. That's why we restrict the protein intake in the patients suffering from renal disorders. Besides, incomplete carbohydrate metabolism, incomplete fat metabolism are going to release hydrogen ions into the circulation. That is, incomplete carbohydrate metabolism results in lactic acidosis. Okay? Incomplete fat metabolism results in production of acidoacetic acid, ketone, and beta-hydroxybutyric acids. Okay? When the hydrogen ions are released into the circulation, they are neutralized by the base, that is bicarbonate. In the plasma, there is buffer systems are there. What is buffer systems? That are going to attenuate the concentration of hydrogen ions in the serum, thereby maintaining the pH. Okay. So there is bicarbonate system in the intracellular and the extracellular buffer system is the bicarbonate buffer system. Intracellular buffer system is phosphates. Well, having known these terms related to the acid-base disturbance, let us go to the condition metabolic alkalosis. What are the physiological aspects of metabolic alkalosis? Metabolic alkalosis is the result of elevated serum bicarbonate, okay, with elevated pH more than 7.45. So to define alkalosis, the pH should be more than 7.45 in the arterial blood, and to define metabolic alkalosis, it should be elevated serum bicarbonate. Okay. In response to serum elevated bicarbonate, what is the response of the body? It results in elevated pH. Okay. How the respiratory system responds to elevated bicarbonate? It results in hypoventilation in order to elevate the PCO2, but it is limited by the degree of hypoxia. It is dangerous. It results in elevated PCO2 to 55 mmHg, but limited by hypoxia. How the kidney responds? It responds in terms of impaired excretion of bicarbonate due to hypovolemia, reduced GFR, hyperaldosteronism, and hypokalemia. This is more important. Okay? Hypokalemia is the dangerous consequence of metabolic alkalosis. Okay? When there is a volume depletion, it associated with hyperaldosteronism. Why? When there is volume depletion, there is reduced renal perfusion, which triggers the renin-angiotensin aldosterone axis. That results in the retention of sodium and chloride and loss of potassium. That results in hypokalemia. Okay? Metabolic alkalosis is associated with hypokalemia, sometimes hypovolemia with reduced GFR, okay, and hyperaldosteronism. What happens in 2-hydrogenase in metabolic alkalosis? As such, hydrogenases are the metabolic products in the body, which I told you. Its concentration is very low in the body, that is to the extent of 40 nanomoles per liter. It is inversely related to pH. The amount secreted, that is intake, and amount excreted determines the balance of pH and intracellular in the intracellular and extracellular compartments. That's what happens usually. Hydrogen ion is the metabolic product in the body. As I told you, incomplete carbohydrate metabolism, incomplete fat metabolism, and the protein metabolism is associated with the production of hydrogen ions, right? And the balance is related to the input and the output of the hydrogen ions into the body. That results in the pH of the intracellular or extracellular compartments. That is in turn maintained by buffer systems. What are buffer systems? Buffer systems are those which will attenuate the change in pH when an acid or base is added to the fluid compartment. There are two buffer systems, intracellular and extracellular. Extracellular buffer systems are bicarbonate system. Intracellular buffer system is phosphate buffer system. How the acid-base balance is brought about. There are two important organ systems that regulate the acid-base balance. There's always tendency to produce acidosis or acidemia. Acidemia is the condition wherein pH of the blood is less than 7.35. Acidosis is the pathological process that results in acidemia. That's what it is. The same alkalemia is the situation wherein pH of the blood is more than 7.45, and alkalosis is the pathological process that results in alkalemia. These are the meaning of the different terms used in acid-base disturbance. Well, what are the two organ systems that are responsible for acid-base balance? Lungs and kidney. Lungs deal with volatile acids, bicarbonate deal with non-volatile acids. So, volatile acids are related to the carbon dioxide concentration. So, by eliminating carbon dioxide through the breathing, lungs control the acid-base balance. Kidneys deal with non-volatile acids by the absorption of bicarbonate and by secretion of hydrogen ions into the lumen. How do the lungs and kidneys play the role in the acid-base balance? Well, carbon dioxide is produced by metabolic activity. You know, carbon dioxide is a weak acid. When combined with water, produces carbonic acid, a weak acid. But in the presence of carbonic anhydrase, it is again split into bicarbonate and hydrogen ions. Carbonic acid is a weak acid. Yes. That's why carbon dioxide is a weak acid. This results in the stimulation of respiratory center, results in the increased elimination of carbon dioxide. Okay? Indirectly, it reduces the hydrogen ion concentration, but cannot compensate the loss of bicarbonate, which occurs as an attempt to neutralize the endogenous hydrogen ions. So what is happening during the metabolic pool? The metabolic pool, there is regular production of carbon dioxide, okay, and regular release of hydrogen ions into the circulation. But coming to the carbon dioxide, which combines with water to produce carbonic acid, okay, that is a weak acid. But respiratory center is stimulated once there is rising carbon dioxide level, thereby eliminating the carbon dioxide through breathing. Okay, carbon dioxide is eliminated, but hydrogen ions that are released are going to consume bicarbonate, thereby there is need to generate the bicarbonate molecules that are consumed by the hydrogen ions. So that is brought about by kidneys, which secrete hydrogen ions in the tubular lumen and absorb bicarbonate. Okay, that is the role played by lungs and kidneys in order to maintain the acid-base balance. Then coming to metabolic alkalosis in particular. Excessive base or alkali in the blood is called alkalosis, commonly due to emesis or diuresis. So metabolic alkalosis is secondary to most commonly either to vomitings or diuresis. Develops in two stages. Remember this. Number one is generation and maintenance. Metabolic alkalosis develops in two stages. In the first stage, generation of metabolic alkalosis. In second stage, maintenance of metabolic alkalosis. This is the result of elevation of pH, increase in bicarbonate in the serum. Okay, well, that is a term used for alkalemia. That is, elevated pH is called alkalemia. Yes, but anyway, the process that results in the acidemia, alkalemia is alkalosis. Respiratory compensation occurs with a decrease in ventilation, resulting in retention of carbon dioxide. Respiratory compensation number exceeds the PCO2 beyond 55 to 60 mmHg. Respiratory compensation results with the retention of PCO2, but that cannot exceed beyond 55 to 60 mmHg. Okay, that is limited by the onset of hypoxia. Well, carbon dioxide raises 7 mmHg for each 10 milliequivalents of bicarbonate. Alkalosis is less dangerous compared to acidosis. Alkalosis is associated with the disturbance in mineral metabolism, complicate the situation. What is the mineral metabolism that complicates the alkalosis? That is hypokalemia and hypocalcemia. As such, alkalosis, again two types as I told you, metabolic alkalosis and respiratory alkalosis. Factors causing metabolic alkalosis. Let us see what are they. What are the factors that results in metabolic alkalosis? Because of the loss of hydrogen ions from extracellular fluid. Okay, when there is loss of hydrogen ions, there is elevation of the pH. Elevated pH results in alkalosis. The hydrogen ion loss could be through GAT, through renal, or intracellular shift of hydrogen ions, or cystic fibrosis. GAT causes either to persistent vomitings or NG aspiration, congenital chloriduria, or villus adenomas, wherein there is loss of hydrogen ions. What is the physiological mechanism? Hydrogen ions secreted in the gastric fluid, that everybody knows. Bicarbonate is produced in intestinal secretions. Okay. So normally there is no net loss of hydrogen ion. Okay. While secreting the bicarbonate into the intestinal lumen, there is retention of hydrogen ions. Okay. When hydrogen is secreted into the gastric fluid, there is conservation of the bicarbonate. Okay. Here, hydrogen ions are secreted into the gastric lumen. Okay. And bicarbonate is retained. Whereas bicarbonate is secreted into the intestinal lumen and the hydrogen ion is retained by the luminal cells. So as such, there is no net loss of hydrogen ions. Okay. This balance is disturbed in excessive vomitings as a result of loss of hydrogen ions and excessive retention of bicarbonate. That is aggravated by hypokalemia and hypovolemia. Okay. Hypokalemia results in, again, excessive loss of hydrogen ions in the tubules. Hypovolemia also results in the loss of hydrogen, which aggravates again the metabolic alkalosis. Because hypovolemia triggers renin-angiotensin-aldosterone mechanism, which in turn causes the loss of potassium ions that results in hypokalemia. Hypokalemia in turn results in the shift of hydrogen ions from the intracellular compartment into the tubular lumen. That aggravates the alkalosis. What are the renal causes? First one, we touched on the GIT causes, then renal causes of metabolic alkalosis. Most common cause of metabolic alkalosis is the renal cause, like loop diuretics, thiazide diuretics. Delivery of excess sodium to the distal tubule increases hydrogen ion secretion. Okay, when you are using the diuretics, there is more amount of sodium is delivered to the distal tubule. That results in the increased hydrogen secretion. Well, there is secondary hyperaldosteronism because loss of sodium along with the loss of free water, that is the action of diuretics resulting in increased urinary output. When there is increased urinary output, there is volume depletion. That triggers aldosterone secretion, resulting in secondary hyperaldosteronism. This results in increased secretion of potassium more than bicarbonate. Reduction of excess of bicarbonate. That results in alkalosis with loss of potassium. Okay, this is the situation we get in the metabolic alkalosis. That is hypokalemic alkalosis with volume depletion. There are certain syndromes, Bartter syndrome, Liddle syndrome, or other renal causes. Intracellular shift of hydrogen ions. That results in, again, alkalosis. Fall of serum potassium to less than 2 milliequivalents per liter. Oh, very dangerous. Movement of potassium into extracellular compartment due to concentration gradient. Well, when there is fall of serum potassium to less than 2 milliequivalents per liter, okay, there is movement of intracellular potassium into the extracellular compartment because of concentration gradient. Potassium is the intracellular cation. Its concentration is higher, much higher than in the extracellular fluid. So there will be movement of potassium from the intracellular compartment to the extracellular compartment because of concentration gradient. Okay. Hydrogen ion shift into the intracellular compartment in exchange with the potassium ion to maintain electrochemical neutrality. That what happens in the hypovolemias resulting in metabolic alkalosis secondary to the renin-angiotensin aldosterone axis being stimulated. This results in the extracellular alkalosis and paradoxical aciduria. Okay. Cystic fibrosis. Loss of sodium and chloride in the sweat, volume contraction, hypokalemia, and alkalosis. Similar mechanism. Then increased bicarbonate in the ECM. What are the situations when you take the bicarbonate precursors like citrate as an anticoagulant in blood transfusion, FFPs, frozen, fresh frozen plasma, and renal replacement therapy. They are also used the anticoagulants that results in alkalosis. Then alkali administration, bicarbonate during resuscitation, parenteral nutrition, milk alkali syndrome, calcium containing antacids. Then drugs, chronic use of aluminum containing antacids and salicylate intoxication also results in alkalosis. So these are the factors so far described that results in metabolic alkalosis. Now factors maintaining metabolic alkalosis. So under this heading, we describe the factors causing metabolic alkalosis. What are the factors that are causing metabolic alkalosis? I told you, loss of hydrogen ion from ECF. Either it could be gut causes or renal causes. Intracellular shift of hydrogen ions that depletes the concentration of hydrogen ions in the serum, thereby resulting in alkalosis, cystic fibrosis, increased bicarbonate in ECF, secondary to bicarbonate precursors, alkali administration and drugs. So those were the factors that are causing metabolic alkalosis. Then what are the factors that maintain metabolic alkalosis? Inability of kidney to excrete bicarbonate due to volume contraction, hyperaldosteronism, hypokalemia, chloride depletion, and combination of all. When this situation comes to this stage, this results in the perpetuation of the alkalosis in the system. How do they manifest it? What are the clinical features related to alkalemia? That is hypoventilation leading to hypoxemia, related to etiological cause, related to electrolyte disturbances. So, metabolic alkalosis symptomatology or clinical phases can be due to 1. Related to alkalemia in the form of hypoventilation leading to sometimes to hypoxemia. In an attempt to compensate metabolic alkalosis, lungs respond in terms of hypoventilation, but it has to be limited, not to the extent of hypoxemia, right? Related to etiological causes, related to electrolyte disturbances. The manifestation secondary to the metabolic disturbances. Hypokalemia and hypocalcemia. Hypokalemia causes muscle weakness, cardiac arrhythmias, polyuria due to impaired urinary concentration. Hypocalcemia, it is as in muscle cramps, corpopedal spasm, and convulsions. Look, when there is electrolyte disturbance associated with metabolic alkalosis, it complicates the clinical situation. Okay? So you must be mindful of the situation of electrolyte disturbances when you are encountering a case with metabolic alkalosis. What are the cardiovascular disturbances? It results in hypotension, hypovolemia, and reduced cardiac output, sometimes supraventricular and ventricular arrhythmias. Then it also results in the manifestation of disturbance of nervous and muscular system. Alkalosis results in increased acetylcholine, reduced calcium, increased nerve excitability, paresthesias, muscle cramps, and tetany. Alkalosis results in hypocalcemia resulting in tetany. And central nervous system, there could be nausea, disorientation, stupor, ultimately coma. Then how do you go for diagnostic evaluation? Take the history whether the patient is suffering from GI disturbances in the form of diarrhea, vomiting, etc. Is the patient suffering from renal issues? Okay, or is the individual is taking diuretics for a longer time? Having taken the history, go for the physical examination. Signs of volume depletion or signs of hypervolemia. Signs of volume depletion in the form of dehydration, hypotension, or shock. Signs of hypervolemia, breathlessness, and respiratory distress and basal crepitations. Then go for blood gas analysis. You know the pH, you know the PCO2, you know the bicarbonate levels. Okay, you also know the serum calcium levels. Based on that, you know the clear situation related to metabolic alkalosis and other electrolyte disturbances. Go for the serum electrolytes in particular and urinary chloride. Metabolic alkalosis with hypovolemia. Renal or extrarenal causes. Could be hypovolemia, reduced filtration of bicarbonate. Hypokalemia results in increased absorption of bicarbonate. There is chloride depletion and low urinary chloride less than 15 milliequivalents per liter. But there is good response to sodium chloride infusion. The condition metabolic alkalosis with hypokalemia is associated with renal or extrarenal causes. As we mentioned, what are the extrarenal causes? That is emesis and diarrhea. What are the renal causes? Diuretic administration. Associated with reduced filtration of bicarbonate. Okay. Hypokalemia with increased absorption of bicarbonate. Hypovolemia results in reduced filtration of bicarbonate. So, in order to retain bicarbonate. Hypokalemia is also the increased absorption of bicarbonate. Okay. This again results in the alkalosis. There is chloride depletion and low urinary chloride and good response to sodium chloride infusion. Renal causes. How do you diagnose? Diuretics and loop thiazide diuretics. Metabolic alkalosis with hypovolemia. Secondary hypokalemia and hypovolemia and hyperaldosteronism. 3 to 50% on diuretics, they suffer. Thiazide increases bicarbonate by 2 to 7 millicalories per liter. Loop diuretics increases up to 15 to 20 millicalories per liter. Urine chloride drops to less than 15 millicalories per liter. Bartter syndrome is a rare syndrome with metabolic alkalosis, hypokalemia, hypochloremia, hyperuricemia, and increased renal angiotensin mechanism. Normal blood pressure, increased urinary chloride, and there is hypertrophy of the juxtaglomerular apparatus system. Gentleman syndrome, again, is a rare situation associated with metabolic alkalosis, hypokalemia, hypomagnesemia, and hypocalciuria. Decreased urinary chloride in this particular Gentleman syndrome. Distal tubular defect with sodium chloride loss that results in hypovolemia, renin-angiotensin aldosterone stimulation, muscle weakness, cramps, tetany, and seizures. There is hypotension, dizziness, prolonged QT interval. In this particular syndrome, there is urinary chloride is low. Then coming to the extrarenal causes. It could be upper GI causes or others. Okay. Upper GI causes like vomiting, NG aspiration, results in loss of hydrogen ions, bicarbonate retention, volume depletion, leading to hyperaldosteronism, hypokalemia, and hypochloremia. Others being laxative abuse, cystic fibrosis, chlorodynia, chlorine deficient formula infant feedings. These are all extrarenal causes resulting in hypovolemic metabolic alkalosis. In this, there is elevated urinary chloride, not responsive to sodium chloride infusion. In hypervolemic metabolic alkalosis. In all these situations like hypovolemic metabolic alkalosis, there is a good response to sodium chloride infusion. In hypervolemic metabolic alkalosis, no response to sodium chloride infusion because there is already elevated levels of serum chloride, so elevated urinary chloride in the urine. This is again divided into with hypertension, without hypertension. With hypertension is the result of mineralocorticoid excess, primary hyperaldosteronism, Cushing syndrome, renovascular or renal artery stenosis, and Liddle syndrome. This is associated with hypertension. Without hypertension, without elevated renin, without elevation of mineralocorticoids, excessive intake of alkali as a result of blood transfusions. Okay? Then how to go about treatment? Treatment of cause should be done. Fluid therapy with normal saline, potassium supplementation, acetazolamide is going to play a role. Infusion of HCl and ammonium chloride, hydrogen chloride or ammonium chloride, or arginine chloride. In resistant cases, go by dialysis, and the prognosis depends upon the cause. Well, thank you so much for patient listening. And I tried to bring out a brief account, but the topic has become very extensive because there are many causes of metabolic alkalosis. Okay, and the clinical presentation of metabolic alkalosis is wide range of symptomatology affecting the different systems, taking from the respiratory to the central nervous system. So I have presented you all the features in detail related to metabolic alkalosis. Well, once again, thank you for patient listening. We'll meet again in next class. Until that time, if you like my video, please subscribe, and until that time we meet in the next class. Bye bye.